This model is a model of a spine. This is depicting the treatment of spinal cord stimulation. Spinal cord stimulation, or the more formal term is dorsal column stimulation, is to actually be able to block pain signals when somebody, for instance, has severe pain going down their leg, pain in their back that hasn't responded to conservative management. Maybe they've even had back surgery and they're still having some pain. We're able to actually put what are called leads, they look like wires basically, above where the surgical area is and intervene before the signals go up to the brain. So that's really what it does. And it stimulates actually what are called inhibitory neurons. So human beings are complex. You've heard about fight or flight. If a lion is going to bite your leg, you're not going to feel that pain. You're going to try to survive and run away. And then after that adrenaline rush, you start feeling the pain severely. You have neurons that are really complex in your spine that actually inhibit pain signals as well. And this is actually the path that this uses and blocks these sensory neurons in the dorsal column of the spine. So once we put the leads inside, you're asleep, you don't remember or feel anything when we do that. In the trial, the wires are just taped onto your skin. And you go home and we make sure that we can cover the area that hurts. And then of course we're looking for amount of relief that you get as well. I would say with our trials, we're around 88% trial to implant. I would say nationally in good, solid fellowship trained practices, it's probably at least 80%. But it's a great modality when you're talking about 87% success rate. And this is not something where, you're just gonna, accept that. These are people with really severe pain. If not, no one's gonna get an implant. It's like, this is basically like a pacemaker for the spine. So we put the wires in, they go home, 5 days later, come back. If they say, this is the greatest thing since sliced bread, then we'll schedule them for the implant. The implant probably takes us about an hour, hour and a half. It's done in 2 ways. It can be done by a pain management doctor. We put 2 leads inside the epidural space with what we call percutaneously. We just use a needle, go in the space, and then feed the wires through it. That's what percutaneous means. That's what this is depicting here. That's one way. And then all we do is we put the battery in the upper buttock area. There's a rechargeable and a non-rechargeable model of these, depending on if you're older, if you don't want to really deal with the recharging on a daily basis. Advantage of rechargeable ones is they last longer. But usually the non-rechargeables, 5 years at least. So it's great for their relief, even if they use it a lot. And what we'll do is we'll just tunnel the wires from the little middle incision in the back to the pocket in the upper buttock area. So you have 2 incisions about yay big, 2 inches each. The other way that it's done can be done by a neurosurgeon or an orthopedic spine surgeon. Similar idea with these leads, but we have what's called a laminectomy lead. It's a flat lead. It's not these conical leads. The advantage of that is that it takes less current to drive. It takes less power and energy to drive the signals in, and therefore the batteries can be a little more efficient. And there's less chance of the leads moving or migrating, which is probably around like 5% in the percutaneous fashion of putting them in. That being said, the disadvantage of that is it's a little more painful, because you have to actually do a laminectomy and take a little piece of the bone and put the leads in. But overall, hour and a half, patients do very well. In that case as well, with the laminectomy lead, we just tunnel it. A lot of doctors do that at Disc as well. Dr. Mezzawala is a big implanter, and Dr. Dorsey, he does that as well.